Hello, everybody. Welcome to Nextillo. The wonder has a name. Hi, I'm Dr.Azmi Mohsin, professor and faculty of Nextillo. I'm going to start this lecture on brachial plexus. And before that, let me thank our director, Dr. Sunil Sharma sir, and the co-founder team of the Nextillo app. Okay, so here I'm going to start with this topic, brachial plexus. I hope you all are familiar with brachial plexus. That is like a very beginning topic for all medical undergraduates. Starting from the upper limb, this is, I think it's the first or second lecture. So let's be prepared. We're starting with brachial plexus. Okay, so now to know about brachial plexus, first of all, you need to know about the typical spinal nerve, because you know that brachial plexus is a plexus of the anterior primary rami of the spinal nerves, the cervical nerves, including the T1 nerve. Now, before that, look here. Now, this is a spinal segment, right? And a spinal segment has this dorsal nerve root, which is a sensory root, and the efferent or the motor root. Together, they join here to form the spinal nerve. This thing which comes out through the intervertebral foramen is called the spinal nerve. And you know that in the case of cervical spinal nerves, these spinal nerves, they emerge from above to their numerically corresponding vertebrae. And in thoracic segments and down below, these spinal segments will emerge from their numerically corresponding vertebrae, below to the numerically corresponding vertebrae. And this change of pattern is because you have 8 cervical nerves and you have only 7 cervical vertebrae. So when this nerve comes out, then soon it divides into 2 ramus, a dorsal primary ramus and a ventral primary ramus. So remember that this dorsal primary ramus winds behind and then split into medial and lateral branches to supply the axial musculature, the intrinsic muscles of the back, as well as it gives the cutaneous branch, which also splits into medial and lateral divisions to supply the skin on the back, including the nape of the neck and the occipital region. Now, this ventral primary rami, right? So it winds around here, especially when talking about the intercostal nerves, it reaches into the intercostal spaces. And before that, let me tell you that to this anterior primary rami, there are gray and white rami communicantis to which is attached the sympathetic ganglion. We will study about this sometime later on. Right now, look here. This is the anterior primary rami, also called the ventral primary rami, which winds around the trunk wall. Upper 6 thoracic nerves, they confine to the thoracic region, but the lower 6 thoracic nerves, they're called the thoraco-abdominal nerves. They also supply the anterior abdominal wall. Now, when they reach in the mid-axillary line, they give this lateral cutaneous branch, which perforates the intervening structures and then becomes subcutaneous and splits into anterior and posterior divisions to supply the skin here between the anterior and posterior axillary lines. There's a lateral thoracic and abdominal walls. While itself, this anterior primary rami continues in the intercostal spaces or into the anterior abdominal wall in the rectus, perforates the rectus sheath, and then splits into, when it reaches in the superficial fascia, it splits into medial and lateral divisions to supply the skin. So this is a pattern of a typical spinal nerve. So make sure you remember now this brachial plexus, which what we're going to study, is not formed by the spinal nerves, rather it is formed by the anterior primary rami. And not only this brachial plexus, also all the plexuses, cervical plexus, lumbar plexus, lumbosacral plexus, all of these plexuses, they are derived from the anterior primary rami. Okay, so let's begin with the brachial plexus. Now, the brachial plexus here you're seeing the nerve roots. You know, when we call it as a root, I told you already that a nerve root is a different thing. Nerve roots are those roots which join the spinal segments. So it is actually a misnomer, or you can specify it by saying it as roots of brachial plexus. Now, these are not the roots of spinal nerve. Make sure. So this we call as the roots of the anterior primary rami. Right. So when it emerges from the intervertebral foramen C5, C6, C7, C8, and T1, I told you through which intervertebral foramen these anterior primary rami are emerging. You have this idea. And before starting with that, let me tell you that there is sometimes a prefixed brachial plexus where there's involvement of C4 spinal segment as well, and there's less of T1 involvement. And post-fixed brachial plexus, there's sometimes T2 gets involved with less of C5 involvement. Okay, now the location of these roots of the anterior primary rami, they are actually paravertebral in position. And when you dissect the cadaver, you will find you will not be easily able to see these roots. Why? Because they are covered by splenic muscles. Splenius anterior covers the root from the front, and splenius medius covers this root from behind. So in between these two muscles, these roots emerge, right? And then they descend downwards and laterally towards the axilla in the form of trunks. Now, C5, C6 join to form the superior trunk, C7 continues as the middle trunk, and C8, T1 continues as joined together to form the inferior trunk. Now, these trunks, by the time they have descended down, they have reached the posterior triangle of the neck. And to be more precise, in the lower portion of the posterior triangle of the neck, remember the posterior triangle of the neck has been divided by the inferior belly of Mohsin into a superior triangle, the occipital triangle, and the lower triangle, the supraclavicular or the subclavian triangle. So the trunks are actually located in the subclavian or the supraclavicular triangle. Then these trunks, they split into divisions. All these trunks, they split into anterior and posterior division. You can see this is the anterior and posterior division, the superior trunk. This is the anterior and posterior division, the middle trunk. Inferior trunk also splits into posterior and anterior divisions, right? So these trunks, where will you find them in a cadaver or in a living subject? These trunks are, these divisions actually, they are positioned just behind the clavicle. Means these are the portions which are entering into the apex of axilla. You know, axilla is a truncated pyramid. So through that apex, you know, there's a anterior, it's the clavicle, posterior, it's the superior border of the scapula, medial, it's the first outer border, the first rib. So that's the space which is the apex of axilla. Through that, the divisions enter into the axilla. Now in the axilla, now this is important to understand how these cords are formed. Remember the anterior division of the superior and middle trunk, they join together from the lateral cord. The posterior division is formed by the union of the posterior divisions of both, all of the superior, middle, and inferior trunks, their posterior divisions join to form the posterior cord. And continuation of the anterior division of the inferior trunk is called the medial cord. Now, important is this, that, you know, the axillary artery, which is one of the main content of the axilla, that's been divided by this, you know, under the cover of this tendon of pectoralis minor. It's divided into first, second, and third part. The first is proximal, and the third is distal to the pectoralis minor. So all this, the cords actually, they are in close approximate relation with the second part of axillary artery. Now these cords will give many branches, various branches. They will start and supply the musculature of the upper lip. Some of them will continue, like the median nerve, the radial nerve, the ulnar nerve. They will have a long length and they will reach up till the hand. So we're going to study about all of this in detail. Now here you're seeing are the branches or the nerves arising from the brachial plexus. Have a careful look here. What I'm telling is these are the roots of brachial plexus. Remember, these are not the roots of spinal nerve. Now, when this, if it's asked like what are the nerves arising from the roots of brachial plexus, so you can say here, see here that there are two nerves which arise from the roots. One is the dorsal scapular nerve. This dorsal scapular nerve, it soon descends down behind under the cover of the second layer of the muscles of the back, means it descends down behind to levator scapulae, and it descends down behind the rhomboides minor and major. And that's why this nerve is also called nerve to levator scapulae, nerve to rhomboides, right? Okay, and it is accompanied by the deep branch of the transverse cervical artery, which also descends along to the medial border of the scapula there. Now, the another nerve here you're seeing is this nerve. This is arising from the roots of C5, C6, and C7. It soon descends down along the lateral thoracic wall in the mid-axillary line over to the outer surface of this muscle, serratus anterior. As you know, it has 8 digitations. Remember, nowadays, MCQs are being asked like which muscle is innervated on the outer surface or on the deeper surface, right? So remember that this nerve, long thoracic nerve, innervates the muscle on the outer surface, and it gives out, slips to each of the digitations. And don't forget that serratus anterior, although it has 8 divisions, but there is 1.5 division that takes origin from the second rib. So this long thoracic nerve, it descends down in the mid-axillary line. In case if it's asked like what other nerve arises from the roots of brachial plexus, you can add up to this. There is phrenic nerve, because phrenic nerve takes origin from C3, C4, and C5. So it also gets a contribution. Phrenic nerve also gets a contribution from C5 as well. Then, as I told you, these roots will join to form the trunk, upper trunk, middle trunk, and the lower trunk, right? And the position of these trunks, I have told you, it's the lower portion, the posterior triangle, the supraclavicular or the subclavian triangle. Now, in case if it's asked, what are the nerves arising from the trunks of brachial plexus? As you can see, there are no nerves arising from the middle and inferior trunk. It is only the superior trunk which gives origin to 2 nerves. One is suprascapular nerve and other is nerve to subclavius. So nerve to subclavius soon descends down below because it's somewhere in the same region, very in close approximation to the posterior surface of this clavicle. So it soon slips down and supplies this small triangular muscle on the undersurface of clavicle, that is subclavius. Then supraclavicular nerve, it's very important. Remember, it will descend downwards and laterally along the superior border of the scapula, and there is this suprascapular notch bridged by a suprascapular ligament. So this nerve will pass N for nerve and for niche. So the nerve will pass below the suprascapular ligament. A for artery, A for above. Suprascapular artery will pass above the suprascapular ligament. Anyway, so this suprascapular nerve in its course will also supply, this acromioclavicular joint, and will also supply this muscle supraspinatus in the suprascapular fossa, and will then cross this glenohumeral joint, spinoscapula and glenoid fascia. There is a notch, glenospinoidal notch. So between the spine and glenoid fossa, that it will descend down and will reach into the infraspinous fossa to supply infraspinatus as well. So that's the course of suprascapular nerve. Now they're further descending down and reaching here into this behind the clavicle, retroclavicular in position. These are the divisions of brachial plexus. You have no branches arising from the divisions of brachial plexus. This can be an MCQ in itself. Which portion of the brachial plexus doesn't give any branches? Roots, trunks, division, chords. So simple, right? You have an MCQ here. So divisions of the brachial plexus do not give any branches. Then we'll talk about the chords. Chords are a content of axilla in close relation to the second part of the axillary artery, and that's from there it actually gets the names. The names lateral cord, medial cord, posterior cord. These are the names of these chords in relation to the second part of axillary artery. Okay, so then look here. This lateral cord, it's giving origin to 3 nerves here. You can see is the lateral pectoral nerve. Then it gives rise to the musculocutaneous nerve, and it continues as the lateral root of the median nerve. Okay. Then here you're seeing is the medial cord, most medial in position. This medial cord will give this nerve, medial pectoral nerve. This medial pectoral nerve will also give a communicating branch to the lateral pectoral nerve. Remember this, both these muscles will supply pectoralis major and minor. And don't forget, if it's asked which nerve pierces the clavipectoral fascia. So it's this lateral pectoral nerve which pierces the clavipectoral fascia. Then this medial cord, it also gives these cutaneous branches. It will give medial cutaneous nerve of the arm. Remember, it will supply the arm in the lower portion of the medial half of the arm, while the upper portion, medial half of the arm is innervated by intercostal brachial nerve, which is a lateral cutaneous branch from the second thoracic nerve, which also supplies the skin of the axilla. Okay, so then your medial cutaneous nerve of the arm, which continues and supplies the skin on the medial side of the forearm, and it'll also give, a branch which is actually rather the continuation of this nerve, and that's the ulnar nerve. And then it gives this branch here, this is called the medial root of the median nerve. So both the lateral root of the median nerve and medial root of the median nerve, they join together to form a median nerve. So you can see there is a gap created between the two roots, of the median nerve. So this gap actually provides the passage of axillary artery. While this posterior cord, you can see it also is giving branches here. It gives out this upper subscapular nerve, lower subscapular nerve, and between the two is the thoracodorsal nerve. Now, let me tell you that the root numbers, of course, there are questions asked sometimes in exams regarding the root numbers. So most of the nerves, you can, if you know to draw the circuit diagram, like I showed you the previous image, right? So it is easy to calculate the root numbers of the branches through the circuit diagram. But there are few nerves for which you have to learn the root numbers, because the spread of this nerve fibers, the axons within the nerve, they emerge out according to the myotomal spread. Just like you have a dermatomal spread, similarly is the myotomal spread of these nerves. So remember this upper subscapular nerve, lower subscapular nerve, and the axillary nerve, they will be having root numbers C5, C6 only. But then down below is this thoracodorsal nerve. This will have root numbers from the middle three segments, C6, 7, and 8. That's the root numbers for thoracodorsal nerve. And then it also gives, it actually continues down then as radial nerve, right? The continuation of the posterior cord is actually called the radial nerve. Maybe you might finding it to be fast, but let me tell you what I'm teaching you right now is through this PowerPoint presentation, and it's not easy to write it here on this presentation. And if you have a curiosity to know in detail if, how, when, every sort of your questions will be sought out in detail. Actually, they're all preloaded lectures of mine, and they are handwritten, drawn images as well. They're already uploaded in the Nextillo app. So I would suggest you to, if you want to learn the details about it, so you should actually download the Nextillo app and subscribe to it. So let's see where it is located here. Now you're seeing in this image is the cervical spine, right? And this is skeleton of the thorax. So what you're seeing is that through this inlet of the thorax, it's the subclavian artery and subclavian vein, they're crossing the upper surface of the first rib. And behind to that will be the trunks of brachial plexus. So remember T1, I told you, T1 will be emerging from below T1 thoracic vertebrae. And that will be a content of superior mediastinum. So remember, we are not actually correct to say that the brachial plexus is a content of neck only. Brachial plexus also is a content of the superior mediastinum, because T1 T1 root of the brachial plexus is a content of superior mediastinum. So both C8 and T1, when they join, they form the lower trunk, which actually rides over to the upper surface of the first rib. And that's how these trunks are formed. You can see these are the nerves to the upper limb, and this is how, you know, that they reach into the axilla. And in the axilla, they're so closely related to this axillary artery. And one thing, the green color thing which you're seeing here, what is this? You know, all this nerves, when they're emerging from the intervertebral foramen, I told you they will be covered by scalenus anterior and scalenus medius from behind. All these muscles, they will be covered by a layer of the deep cervical fascia, and that is called the prevertebral fascia. So if it's all covered by the prevertebral fascia and these nerves have to emerge out, what will they do? They will either have to pierce that fascia or they will wear the fascia along to the course, and that is what happens. So this prevertebral fascia, which invests these muscles, that extends along to the course of the brachial plexus, enclosing the subclavian and axillary artery as well. So, and that continuation of the prevertebral fascia is called the axillary sheath. So that axillary sheath now reaches into the axilla, enclosing the axillary artery and the trunks and cords of brachial plexus. Theoretically, if you see that this axillary sheath reaches down and continues and joins to this space of cubital fossa, but that's just a theoretical point. But you should remember that this prevertebral fascia extends to form the axillary sheath, which encloses the brachial plexus and the axillary artery. Here you're seeing is the exact location of the brachial parts of the brachial plexus, which I already told you. You can see these are the roots of the brachial plexus. They are paravertebral in position, which will not be visible because of the scalenii muscles. Then you're seeing is the trunks of brachial plexus. These are the content of the supraclavicular or the subclavian triangle. Then you're seeing are the divisions of the brachial plexus, and you can very easily see that these are located behind the clavicle, retroclavicular in position, which if it's asked what structure, what portion of the brachial plexus enters into the axilla, it is the divisions of brachial plexus which enter into the axilla. And then these are the cords, which are the content of axilla. I believe if you have a bigger screen, you can appreciate that there is this suprascapular notch bridged by suprascapular ligament, and there is this suprascapular nerve passing below to this ligament. Okay. Then, as you know, that there's a spread of, you know, because in the embryo, right? At the 26th day of intrauterine life, if it's asked like which limb bud appears earlier in an embryo, is it the upper limb buds or the lower limb buds? So remember, it's the upper limb buds that appear first around the 26th day of intrauterine life, and very soon, that's like 28th day, it will be the lower limb buds that appear in an embryo. So when these limb buds grow in size, obviously they'll need an arterial supplies, and that's called the axial artery of the limb buds. So it's the axillary artery in the upper limb buds, although it will further divide because embryo keeps growing, right? But initially it's the axillary artery, and down below in the lower limb buds, it's the inferior gluteal artery, which is called the axial artery of the lower limb buds. In an adult, if it's asked like, then it's the artery to sciatic nerve, which is actually speaking the axial artery of the lower limbs. Anyway, so there's, you know, when an embryo, this limb buds appear, they have an upper border and a lower border. The upper border is closer to the head of the fetus. That's called the preaxial border. And there's a postaxial border, which is towards the caudal end of the limb bud. So that limb bud, that when elongates, enlarges, it takes a twist. The upper limb buds, they rotate around 90 degrees laterally, and the lower limb buds, they rotate around 90 degrees medially, right? So that's the preaxial border of the upper limb is laterally placed, and the preaxial border of the lower limbs is medially placed. And that's how, you know, the tibia and radius, they're homologous, but both are 180 degrees opposite. And that's how the compartments also gets changed. Remember, in upper limbs, You have the flexors placed in front, but in the lower limbs, the flexor compartments are placed behind. Extensors in the lower limb are in front, extensors in the upper limb are behind. So all these fundamental things have already been uploaded in my lecture series on the Nextillo app. Please do subscribe and do understand the concepts very clear. So now when this, as I was telling, these nerves will spread along because the limb buds, when they were enlarging, so they were taking, as this limb bud enlarges, they take the corresponding spinal nerve, including the myotome, and then they spread and they elongate. So that's how the spread of dermatome is. So you can see this is the pre-axial border, the radial border. So that's how the C4, C5, they spread along, C6 reaching to the thumb, C7 for the middle digits, and C8 or the little finger, the pinky finger, and T1 along the medial border of the forearm and the lower portion of the arm. And T2, I already told you, it's the intercostal brachial nerve, which innervates the skin on the upper medial side of the arm, including the floor of the axilla. So that's how from pre-axial, they spread out, and from post-axial border, these dermatomes, they converge back to reach to the, and in continuation with the dermatomes of the thorax. Right? Okay. Then it's all what I have already told you. In case if it's asked which nerve winds around the surgical neck of the humerus, obviously you can see it's this axillary nerve which winds around the posterior surgical neck of the humerus, right? So fracture neck of humerus, most commonly asked like which nerve is going to be injured, right? And the symptoms and all, there will be flattening of the contours of the shoulder, deltoid paralysis, crutch paralysis, remember saturday night palsy, because radial nerve passes in the radial groove behind to the mid shaft of the humerus. Ulnar nerve passes behind to the medial epicondyle of humerus. So all these places, you can see the nerves, they are in intimate contact with the bony surface, and thereby there's more chances of nerve compression. By the way, in this diagram, which nerve is not in intimate relation to the humerus, the nerves of the arm, if it's asked? So which nerve in the arm is not in contact with humerus? There are two nerves, musculocutaneous and median nerve. These two nerves do not touch the humerus in the arm. Okay, let's move further. This is just an introductory lecture just to tell you how Nextillo is going on working on the lectures to introduce you to with the Nextillo app. You will find all these diagrams and the many other things which I have drawn it on, the pad, everything, self-drawn images. You will understand them well in that app. Okay, now focus here. Here they have included these muscles. If you have seen the first rib, right? The first rib on its upper surface has grooves, right? The groove for those two vessels, subclavian vein anteriorly, and then you have a subclavian artery. And in between those two grooves on the inner border of the first rib, there is a tubercle, splenic tubercle, right? So this is scalenus anterior muscle. Down below it is attached to the splenic tubercle on the first rib. So behind to scalenus anterior, you find is the subclavian artery, and even behind to subclavian artery, you will find is the trunks of brachial plexus. And what crosses the first rib on its surface is the lower trunk of brachial plexus, and behind to that is the middle scalenus anterior muscle, scalenus medius, which also is inserted on the upper surface of the first rib. There is a scalenus posterior muscle as well, but that scalenus posterior is inserted on the second rib, on the outer border. So scalenus posterior is not in direct relation to the brachial plexus. Remember this. Between the two, between the two muscles, it's like this. Scalenus anterior from the front, scalenus medius from behind, and these are the trunks of brachial plexus emerging, including the axillary artery. Why axillary? Because subclavian continues as axillary after crossing the outer border of the first rib. Got it? Okay. And subclavian itself is divided into three parts. By which muscle? By which muscle? Yes, the same muscle I just told you. Scalenus anterior. Okay. Then in the next image here you're seeing is here Here, the long thoracic nerve of Bell, I told you, remember, it was arising from C5, C6, C7 nerve, the roots of the brachial plexus. As you know, it descends down along its course on the outer border of this muscle. And in the mid-axillary line, it is giving twigs to each of these 8 digitations. While you're seeing in the second intercostal space, there is this lateral cutaneous branch of the second intercostal nerve, which elongates. And that's called intercostal brachial nerve, which innervates, which extends to innervate the skin on the floor of the axilla and onto the upper medial side of the arm. Okay. Then here you're seeing is cutaneous anterior has been removed. This is the lower cut portion, the tendinous portion of the cutaneous anterior. The rest of the muscle has been removed to expose the underlying structures, and where you find in the cervical sympathetic chain, right, running onto the anterior surface of the transverse of the cervical vertebrae. This is superior, middle, and inferior cervical sympathetic ganglia. And of course, the roots of the brachial plexus, and behind what you're seeing is the muscle, that's this cutaneous medius muscle. So closely observed to this, I believe you can see my pointer here. This muscle is pectoralis minor. Okay, so these are the second, what are these? These are the chords of brachial plexus. And this artery, when it passes below to this pectoralis minor, this is the second part. So you can see how closely the 3 chords of brachial plexus are in relation to the second part of the axillary artery. Okay. Here in the same diagram, you can see, if you can appreciate that this suprascapular nerve and the rest of the structures are the same. I have already described this diagram. And here you're seeing the other muscles, the long nerves of the arm. Remember the musculocutaneous nerve arising from the lateral cord of the brachial plexus. This musculocutaneous nerve, it enters into the arm by piercing this muscle, that is coracobrachialis. It pierces and supplies coracobrachialis, then runs in between the 2 muscles, between biceps anteriorly and brachialis deep to it. So biceps brachii is innervated on its deeper surface, and brachialis is innervated on its anterior surface by this nerve musculocutaneous, which has an oblique course in the arm, and it emerges laterally below to this lower end of this biceps. And then it continues as, remember, the name is musculocutaneous. So after supplying these 3 muscles, it becomes cutaneous in the cubital fossa and will run along the radial superficial branch of the radial artery, and it will be called as the lateral cutaneous of the forearm. Okay. Then here you are seeing is, from the posterior cord of the brachial plexus, there's this axillary nerve, right? You must be knowing about the superior and inferior triangular spaces and the quadrangular spaces, the intermuscular spaces there. So in the quadrangular space, you're seeing this axillary nerve is passing behind, winding around the posterior surgical neck of the humerus. Then these are the branches of the posterior cord. You can see is the upper subscapular nerve, lower subscapular nerve. See it clearly that this is a multipinnate muscle which is being innervated by these 2 nerves, upper and lower subscapular nerves. And can you appreciate that the inferior subscapular nerve, it even descends down to innervate this muscle teres major as well. So teres major is innervated by the inferior subscapular nerve. And this nerve, thoracodorsal nerve, remember the 3 middle segments of the brachial plexus, C6, 7, and 8. That's the root number for thoracodorsal nerve. It descends down on the posterior thoracic wall under to this subclavius and will descend down and will supply this very important anti-gravity muscle, the rowing muscle, climbing muscle, swimmer's muscle, and that is Latissimus dorsi. So Latissimus dorsi is innervated on its deeper surface. Serratus anterior is innervated on its superficial or the outer surface. After cutting and removing this biceps brachii, as I was telling you, you'll find this nerve musculocutaneous having an oblique course in between the two muscles, and this musculocutaneous with innervate biceps on its deeper surface brachialis. And remember, brachialis is having a dual innervation. It also gets fibers, the proprioceptive fibers from the radial nerve as well. Lately, I mean, there was this university exams going on in many of the medical colleges here, and there's this Chhatrapati Sahuji Maharaj University of Kanpur, right? So there are, I think, 2-3 medical colleges. This GSVM Medical College Kanpur, Saraswati Medical College Unnao, and I think the Hind Medical College Ataria, Sitapur. They all face the same question paper, and there was some questions. There was a question rather regarding the relation of brachial artery and ulnar nerve at the mid of the arm, because everybody knows that it passes, this ulnar nerve passes behind the medial epicondyle of the humerus. And you know, there's a changing pattern of the relation between brachial artery and the median nerve. In the upper half of the arm, median nerve lies in lateral relation to the brachial artery. In the mid of the arm, you can see that because median nerve being lateral becomes the medial most content in the cubital fossa. So that means at the mid of the arm, median nerve crosses brachial artery anteriorly. And in the lower portion, that's a cubital fossa, brachial artery comes to lie laterally and median nerve becomes the medial portion. Now talking about ulnar nerve, you know, is a continuation of the posterior cord of the brachial plexus. So, and it's medially related to the axillary artery as well as to the brachial artery, and it continues to have the same relation up till the upper half of the humerus or the arm. So here at the mid of the arm, there was like a relation thing, you know, lateral, medial, anterior, posterior. That's how the choices were. There was an MCQ. So the answer there, it will be that ulnar nerve lies in medial relation to the brachial artery at the mid of the arm. And then, of course, in the lower portion, the lower portion of the arm is well compartmentalized by the medial and lateral intermuscular septum. So ulnar nerve now leaves the track of the brachial artery and reaches into the back of the lower portion of the arm and will pass behind the medial epicondyle of the humerus. Not to go much in detail because there's less of time to know all the details. You can join and subscribe the app. Okay, now talking some clinical points about this brachial plexus. Many times it comes as a long question, around 10 to 15 mark long question. You have to describe the structure, branches, and as well the clinical and applied anatomy. So winging of scapula is a very common, deformity due to the paralysis of which, injury of which nerve. You must be knowing that it's a long thoracic nerve bell, which innervates this boxer's muscle, and that is serratus anterior. Why boxer's muscle? Because it has it has 8 digitations. The upper 3 digitations, they're inserted onto the medial border of the scapula, onto the costal surface. So when you do this pushing and punching thing, your medial border of the scapula is actually approximated toward the thoracic wall. And of course, if it's paralyzed, what will happen when you pushing and punching, your medial border of the scapula gets elevated, and that appears on the posterior surface, as you're seeing in the image, that it appears like a wing because of the elevation of the medial border of the scapula. Of course, this will also have problems in overhand abduction of the arm. The same person. Why? Because there were 5 digitations, the lower digitations of the serratus anterior, they were inserting onto the inferior angle of the scapula on the costal surface, and they were participating in the lateral rotation of the scapula along with trapezius for the overhead abduction of the arm. So if there is a winging of scapula, remember that same person will also have difficulty in overhead abduction of the arm as well. Okay. Erb's Duchenne palsy, very common anomaly, very common deformity because of the injury to the upper trunk of the brachial plexus. So remember the upper trunk, which was formed by the fusion of these roots of C5 and C6 portion of the brachial plexus. And from there were the two nerves, remember, the two nerves, suprascapular nerve and nerve to subclavius. And that's why this point, some in your undergraduate level, this point has been marked as Erb's point. Okay, so because it's running here, like, in this angle between the neck and the shoulder, so whatever might cause, there is sudden abduction of the neck such that this angulation between neck and shoulder is suddenly increased, that might stretch, right? That might stretch this upper trunk of brachial plexus. Now, this can happen, you can see here, while the act of delivery, right, at the act of parturition also, while handling the, this fetus, there might be stretching between the neck and shoulder, and that might cause stretching of this upper trunk of brachial plexus. And that might be seen later in life as a deformity. And this deformity, you can see that the Erb's Duchenne paralysis, what happens is the arm, because remember C5, C6 paralysis is gone. Now C5, C6 was innervating here, it was innervating here, this shoulder region, right? All the muscles, even the flexors, extensors, they were all being innervated, even the skin here, C5, C6, so everything is lost, right? So remember, what's the skin supply of here, the summit of shoulder? It is C4. It's from the cervical plexus. But the axillary was supply, axillary nerve, the branch, remember, the regimental area, lower half of the deltoid, that all the sensory sensations will be lost there. Then biceps, brachialis, coracobrachialis, triceps, subscapularis, right? All these muscles, they are going to be paralyzed. So what will happen? Your arms will be hanging and suspended by the side, right? You are not adducting it because the adductors are not powerful. They are already paralyzed. So it just simply hanging by the side, and it will be pronate and extended at the elbow, and it will be pronated. Remember, pronator quadratus is down below, right? That will be having C7 component as well from the median nerve. So the hand becomes pronated, and there's a flexion at the wrist. Why flexion at the wrist? Remember, flexor carpi ulnaris, C8T1 through the ulnar nerve. So that has a role. So that's why there is even the medial two tendons of flexor digitorum profundus, they're also innervated by ulnar nerve. So there will be flexion at the wrist. And that's how the position you can see is that the hand by the side, suspended by the side, extended, pronated forearm, and flexed at the wrist. This position of the hand is called porter's tip hand or policeman's tip deformity. That's Erb's paralysis. So this is the deformity you can see because of the injury to upper trunk, and this is the policeman's tip deformity, porter's tip hand. And sometimes during the, as I was telling, during the act of delivery, because of can say is a mega baby or some obstacles in the delivery thing. So because of pulling a baby, maybe into suction even. So if there is, when you're pulling the head, that might increase the neck shoulder angle, that will lead to Erb's paralysis. Or even the bony thing, you have pubic symphysis in front, that might compress upon this angle, the hair and the neck. That even can cause damage to this upper trunk and can lead to Erb's Duchenne palsy. Then you have is a clump case paralysis. Now, this clump case paralysis is because of the injury to the lower trunk of brachial plexus. Now, the lower trunk was being formed by C8T1. And remember, it was the lowest trunk. It was arising, from C8T1, and it will crossing the upper surface of the first rib. So it has to take a jump here because T1 was arising from below T1. That's the content of superior mediastinum. So it takes a jump over the first rib. Right. So if there is a sudden increase in this arm and thorax between the lateral wall of the this lateral wall of the thorax and the arm, this angulation, if suddenly increases, and that can increase like when a person is falling from a height and suddenly he catches hold of something. So there will be a sudden increase in this angle between the arm and the thorax. The sudden increase in the angle will cause stretching of the lower trunk of brachial plexus. Another condition is the shoulder dystocia, right? Where the shoulder pops up out of the delivery canal first. And while doing this, what happens if you're pulling the hand of the baby first, that might also cause the stretching of the lower trunk of brachial plexus. So what will happen? C8T1 is lost. And what was the C8T1 reaching into? Along the medial border of the arm, forearm, and medial border of the hand. That is the course of C8T1. I told you the dermatomal and the myotomal spread. So all the muscles here will be lost. And what were the nerves arising from C8T1? Ulnar nerve, right? And you have is the median cutaneous from the arm, medial cutaneous on the forearm, and the medial root of median nerve. This is very important because if it's injury here, you know, there are 20 intrinsic muscles in the palm, and out of that, 15 intrinsic muscles are innervated by ulnar nerve. The remaining 5 intrinsic muscles, they are innervated by the medial root of median nerve. That also is C8T1. So if lower trunk is injured, all the 20 muscles will be lost. And this position of the hand, remember, you can see here, this Babaji ka Thullu position, right? So this flexion at MP joint and extension in IP joint, this position was being formed by 12 muscles, the 4 lumbaricals, 4 palmar, and 4 dorsal interosseous. All of them were being innervated by C8T1. Out of these 12, 2 muscles, the lateral first and second lumbaricals, they were innervated by medial root of the median nerve. The remaining 12 muscles, the remaining 10 muscles, they were innervated by ulnar nerve. So if clump case happens, all the 12 muscles will paralyze, and what will happen? The reverse of it. The reverse of this Babaji ka Thullu. What is happening here? Focus on it's flexion at MP and extension at IP. But if it's paralyzed, what will happen? The reverse of it will happen. There will be extension in MP joints and flexion at IP joint. For this, you actually need to know the origin and insertion thing, because these intrinsic muscles, they are taking origin here, but they're passing through the interdigital clefts, and then they were inserting along with the extensor digitorum. So they are actually crossing the IP joint from behind. Anyways, you don't have to go that much, because to know the details, you can, again, I would suggest to subscribe to that Nextillo app and the YouTube channels to stay updated. Anyway, so this is a complete claw hand. Remember, it's hyperextension at the MP joints. But many times you must have heard about this partial claw hand. Now, this partial claw hand is when there is only ulnar nerve damaged. So if ulnar nerve alone is damaged, the first and second lumbaricals will be spared, and there will be less of clawing here in the index and the middle finger. Got it? Okay. This is a complete claw hand. Another important thing is Horner syndrome. By the way, if people are listening, let me tell you, there is a gift hamper, or rather, I've included is a question of the day for you guys. So whosoever answers the correct answer, and the first and correct answer will be awarded by the Nextillo team, and that will be his name, and the image, the photograph will be displayed across all the social media platforms of Nextillo app. So stay connected, stay tuned, hardly 5 to 10 minutes more to go, and I'll be bombarding you with MCQs and the question of the day. So stay focused, keep listening. Lastly, here is clump case, right? Clump case is also associated with the Horner syndrome. So let me tell you that the sympathetic innovation, I told you, sympathetic innovation arises from T1, reaches till L2. So sympathetic fibers do ascend up and reach into this, orbits. The sympathetic innovation of the orbit has a course through this inferior trunk as well. So what happens if there is in, clump case, there are chances of Horner syndrome as well. That is loss of sympathetic innovation to the structures of the orbit. And this is mostly unilateral. So Horner syndrome, many times in your exams, there are questions regarding these signs and symptoms. So you should know that there are 5 signs which are appreciated in this Horner syndrome. One is meiosis, That's constriction of the pupil, because mydriasis is a sympathetic phenomenon that is lost. So there will be passive meiosis. Anhidrosis, because loss of secretions here in this mucosal secretions like lacrimal secretions, this loss of these secretions will lead to anhidrosis. Mild ptosis, remember this LPS, levator palpebrae superioris, that muscle has both skeletal and smooth muscle components. The skeletal muscle of the LPS are innervated by oculomotor nerve, and the smooth muscle component, that is called Muller's muscle, that is innervated by the sympathetic fiber. So if that is lost, there will be mild ptosis, loss and drooping of the upper eyelids. Then apparent anaphthalamus. Eyeballs, they also have a fixed position in the orbit. They do not rather touch the roof, nor the floor, nor the medial wall, nor the lateral wall, and even in the anterior posterior axis also, they have a fixed thing. If they pop out, that is exophthalmos. If they sunk in, that is anaphthalamus. So what is making it in fixed position is the retrobulbar fat, as well as down below in the floor of the orbit, there is this muscle called orbitalis, which bridges the inferior orbital fissure. So if that paralyzes, that's a smooth muscle that sinks down, right? So that's why the eyeball also sinks behind, and that's called anaphthalamus. And then there's loss of ciliospinal reflex. You've seen this lioness of the lion when they pick up the cubs. They catch hold of the cubs with their nape of the neck. So when you pinch the nape of the neck in other mammals, they actually wince their eyes, right? And that's called ciliospinal reflex. That also is a sympathetic response, so that also will be lost. Here's the image you can appreciate, and you can guess that we are talking about the Horner syndrome of which eye, the right eye or the left eye. So because you have to appreciate it from the image, so you should look on the ptosis. So you can see there is loss of, this upper eyelid is not in the same level as the upper eyelid in the opposite eye. So this is the normal eye, and here you're seeing is, this one is the normal, and the upper eyelid on this left side is not being elevated, right, completely. So there is a partial ptosis here. So this you will consider as a case of Horner syndrome on the left side. Okay. So it is all. Now, if you are attentive enough and you're interested, stay focused, and I'm going to solve these 5 MCQs for you, and these are all related to the brachial plexus. So let's begin with question number 1. Which is a branch arising from the upper trunk of brachial plexus? Suprascapular nerve, nerve to subclavius, long thoracic nerve, dorsal scapular nerve. Guess your answers fast. Answer to this will be suprascapular nerve. I told you there were 2 nerves, they were arising from the upper trunk, suprascapular and nerve to subclavius. Why suprascapular nerve is the answer? Because let me tell you that sometimes this nerve to subclavius, it takes origin from the roots of C5 and C6. Not always from the upper trunk, but sometimes it takes origin from the roots of C5 and C6, and you have to select the most appropriate answer. The answer will be suprascapular nerve. Now, question number 2, Horner syndrome. I just taught you about this. Horner syndrome produces all the symptoms except. This was again a question in this recently in this Rohilkhand University. Recently in this exam, there was this question: Horner syndrome produces symptoms all except partial ptosis, meiosis, and hydrosis ex ophthalmos. What will be your answer? Any guesses? Okay. Harish Sharma. Yes. Siddharth Patel. You correct. This is exophthalmos, because I just told you about the symptoms here. And some people there, the graduates, I think they attempted it wrong, but you shouldn't make this mistake next time. I have taught you that orbitalis muscle is a sympathetic muscle, which because of this sympathetic innervation, loss and sympathetic innervation, it sags down, eyeball sinks behind, and it is enophthalmos. Okay. Question number 3. Skin of the floor of axilla is innervated by A, B, C, D, medial cutaneous nerve, arm, axillary nerve, musculocutaneous nerve, intercostal brachial nerve. Oh, try attempting it. Skin of the floor of the axilla is innervated by Star Lord. No, no. Onkar Dhale, no. Harish Sharma, no. I taught you about this in the same presentation. Kartike. अभी तो बताया है भैया. B भी नहीं है, no. Axillary nerve भी नहीं. Floor of the axilla, if you elevate, abduct your arms, right? You find the skin below, that's a hairy area, right? So the secondary sexual character, the appearance of these hairs, that skin there, the nerve supply to the skin, nobody has answered. Siddharth Patel even. भैया मोहित, अब तो बता दो. Akansha Kumari, no. Okay, it's time up. I taught you about this. Answer will be intercostal brachial nerve. I taught you in detail. Remember, look here fast. It is the second intercostal space, right? In the second intercostal space, this second intercostal nerve, all these nerves rather, they give the lateral cutaneous branches. And this lateral cutaneous branch from the second intercostal nerve, it elongates and supplies the skin on the floor of the axilla. And it continues to supply the skin on the upper medial side of the arm. And that is intercostobrachial nerve. The name itself is suggesting the answer. Intercosto, because it's an intercost arising from the intercostal nerve. Brachia is what? It's brachium, the arm. So upper medial side of the arm, including the skin on the floor of the axilla, is innervated by intercostobrachial nerve. Understood? Okay. Next, question number 4. Chords of brachial plexus are closely related to. So easy. If you were being attentive in my lecture right now, you will answer it very easily. Choices are first part of axillary artery, second part, third part of axillary artery, or it is the proximal portion of the brachial artery. The chords, lateral cord, medial cord, posterior cord, the names of these chords are according to the relation of these chords with which part or which artery. Fast. Tell me A, B, C, D. क्या लगाया जाए? I'm waiting for the question of the day. Just one more question to go, and then you'll be seeing the question of the day, and that person who answers it correctly will be awarded, will be honored. His image, his photograph, and his or her photograph and name will be displayed across all the social media platforms of Nextillo. So just few minutes to go. Mohit, Parekh, Onkar, Sanjay, very good. It's a very easy. I mean, of course, it's an easy if you are attentive here. So answer here is the second part of axillary artery. You people are correct. Okay, now the last MCQ here. No, see, Gagan, stay attentive. It's the second part. Okay, next, question number 5. Trunks of brachial plexus are content of posterior triangle of the neck, carotid triangle, occipital triangle, or the subclavian triangle. Trunks of brachial plexus are content of. Answer this MCQ. The last MCQ. Choices A, B, C, D. Which is the correct option? Yes, fast. क्या लगाया जाए इसमें? Star Lord is coming with A. Harsh Sharma A. Siddharth Patel A. Everybody is answering A. I think A should be the correct answer if so many people are marking it A. Very good. Ankar Dhale. Everybody is answering is A. Are you people not here since the beginning of this lecture? I emphasized upon this point. There was something special about it that only I have made this MCQ. Guess it fast. Okay, till now everybody has answered as A in this MCQ. I would say those people who have submitted the answer as A, they are not wrong. They're not wrong, but they're also not correct. Because in an MCQ, very good. I don't know ये कौन सी language में लिखा हुआ है. BSMU student. Okay, so to be very, when you have to answer a MCQ, you have to be precise. The people who have answered A as the answer, they are not wrong, but they are also not correct. Because in an MCQ, you have to be precise, and the correct, more precise answer is subclavian triangle, the lower half, the lower portion of the posterior triangle. I told you it's divided by inferior belliofemoid. The lower triangle, that supraclavicular or the subclavian triangle, that's where you find the trunk of brachial plexus. Okay, so it's done. Just the last thing to happen soon. Be prepared. And it's the question of the day. You will see the question. And if any of the participants is from Chhatrapati Shahuji Maharaj University, it is a good chance for you. Anyway, so be prepared. The one who answers it the first and the correct answer, he will be his image, photograph, and everything, you know, the details will be published around social media platforms. So the question of the day is, let's begin. Question is, fibers of C7 from ulnar nerve also supply flexor palmaris, medial half of flexor digitorum profundus, flexor carpi radialis, or these C7 fibers from ulnar nerve are these cutaneous in distribution? This was a question. I have purposely put up this question because there were many students who were asking me the answer for this, and that was troubling them. They found it a new type of question. And why was this confusing? Because above to that, there was another question talking about the root numbers of C7. Oh, sorry, the root numbers of ulnar nerve. So what are the root numbers of ulnar nerve? Ulnar nerve is C8T1. Everybody knows it, like it's the continuation of the medial cord of the brachial plexus. But actually speaking, ulnar nerve do get C7 component as well. So exactly speaking, the root numbers for ulnar nerve is C7AT1. Now answer the correct response here. A, B, C, D. Flexor carpi ulnaris, medial half of flexor digitum profundus, flexor carpi radialis, cutaneous in distribution. अरे भैया बी 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 बी, काफी लोगों ने बी मार्क कर दिया है. सिद्धार्थ पटेल, कार्तिकेय गुप्ता, बच्चाए, संजना पांडे, बी. तो बी अगर ये है तो फिर ए वाला आंसर क्यों नहीं है भाई? अल्नर नर्व ने तो फ्लेक्सर कार्पी अल्नारिस भी इनोवेट किया था, करती है. मीडियल हाफ ऑफ फ्लेक्सर डिजिटम प्रोफंडस की भी नर्व सप्लाई है, बिकॉज द मीडियल टू टेंडन्स, द रिंग फिंगर एंड द लिटिल फिंगर, दे बीइंग इनोवेटेड बाय अल्नर नर्व, राइट? एंड इट ऑफ कोर्स हैज अ क्यूटेनियस डिस्ट्रीब्यूशन एज वेल. चलो सी को हटा देते हैं, बिकॉज फ्लेक्सर कार्पी रेडियालिस इज बाय मीडियल नर्व. So why you think that answer should be B? Because many of you have answered it B. Maybe if it's a guess, then also you're correct, but let's explain this right now. Who answered the correct response and whose was the first correct response, that will be judged by the Nextillo co-founder team. They're also participants here, not me right now, because I'm not focusing on the chat list. So be prepared, the winner of the day will be announced soon. Okay, so let me explain with this question. और D भी आ गया है, ओंकर ढाले, D क्यूटेनियस इन डिस्ट्रीब्यूशन भी हो सकता है. बात तो सोचने वाली है. So let's explain you with this question. This was recently a question in your Chhatrapati Shahuji Maharaj University Kanpur. It was a question there. So the answer to this is those who have marked B are the correct ones. Now this is because of the Martin Gruber anastomosis. No doubt, it would have been a tough question for you guys as an undergraduate. So let me tell you that ulnar nerve, if you know the circuit diagram of the brachial plexus, ulnar nerve gets its root number C8T1 from the medial cord of the brachial plexus. But while it descends down in its course, it does get a contribution or the communicating branch from the lateral root of the median nerve or directly from the lateral cord of the brachial plexus. C7 fibers join ulnar nerve. But sometimes you've been seeing that there is an anastomosis, a nerve anastomosis in the forearm. You know, there are muscles there in the superficial layer of muscles, deep layer of muscles. So between the two layers of the muscle where this median nerve is descending down, there is a communicating branch from the median nerve, which is proximally arising from the medial nerve, and distally it is reaching and joining the ulnar nerve in the mid of the forearm. And that's a communication between ulnar nerve and median nerve in the forearm, and that is called Martin Gruber anastomosis. Remember this. And this communication, after this communication, C7 fibers from medial to median nerve via ulnar nerve will innervate these two tendons. Medial half of the flexor digitum profundus has two tendons for the ring and the little finger. All right, so there you got the B as the correct answer. And that's all for today. Thank you guys for patiently listening me. And last and of course, because if you people finding it interesting, let me tell you, it was a PowerPoint presentation here, but all the lectures that have been uploaded are my self-drawn images with a detailed, relaxed mode of understanding. You'll enjoy those lectures. So please do subscribe to the Nextillo app. Download it first. And there are some few of the lectures there. I think they are open to all also, like a demo lecture. You can watch them. And also subscribe to the YouTube channel of Nextillo. So for learning complete and detailed human anatomy, it will be all the topics, neuroanatomy, embryology, radiological anatomy, everything I'm going to upload it there. So just log in there in your YouTube channel and subscribe it. Also the Nextillo app. Okay, so for complete and detailed human anatomy, subscribe to Nextillo app. Thank you guys. And thank you, Nextillo team, the director, Sunil Sharma sir, the co-founders of the Nextillo app. Okay, good luck, guys. All for today. Bye.